Welcome, and thank you for joining us for our monthly virtual wellness series, the Happy and Healthy Hour. We appreciate that you're taking the time today to connect with us and with the CU Anschutz Medical Campus and our alumni community. I'm Karen Arstead, Assistant Vice Chancellor for Advancement at the University of Colorado Anschutz Medical Campus, and I have the pleasure of working with alumni, faculty, and staff of the 6 schools on our campus, and I'm proud to be able to be introducing today's speaker. For those of you who are here for the first time, welcome to this virtual series. It was provided in response to a lot of our alumni asking for support to cover topics around wellness and help manage their own personal wellness as well as wellness of their communities. And today we're bringing our campus expertise on a topic that impacts all of us. A look at what we can expect in the coming months in regards to COVID-19 and how to navigate our new normal. Before we get started, I would like to ask a couple of questions, and Noelle, who's helping with technology, is going to put up a quick poll just so you can all know who's on this Zoom call today. So I ask you to fill out the form that you should see in front of you right now. It's multiple choice and you can select all that apply. And then in real time, we'll be able to see who the other 100 people are who are on this Zoom call today. And in the meantime, I'll go ahead and briefly introduce our speaker, Dr. Michelle Barron. She received her bachelor's degree from Yale University and her medical degree from the University of Texas Southwestern Medical School, and did her internship and residency in internal medicine at Creighton University, and came to us at the University of Colorado, what was Health Sciences Center, in 1999 to complete her training in infectious diseases. She joined the faculty at University of Colorado in 2003 and is currently a professor of infectious diseases and also helps with disease prevention at University of Colorado Hospital. She's board certified in internal medicine as well as infectious diseases. And I'm going to pass along to Dr. Barron.
Thank you. So there is a way to ask questions on the chat. We're going to reserve most of the time after my talk for those questions, and those will be looked at during this as I'm speaking, so that you all have the opportunity to sort of ask the questions, and then we can try to put them into groupings and then hopefully answer all your questions. And so I picked the title, "The More Things Change, the More They Stay the Same," only because I feel like even though we continue to have knowledge, we continue to have more information, I feel like we haven't necessarily moved forward in terms of trying to answer a lot of the questions that people still have. And so what I will be doing with this talk at the beginning is going over just where we're at now, where I see us going, and then some of the bigger questions that have come up. What about school? What about camp? What about going out to parks? What are things that are safe, maybe not so safe? And how do you try to sort through all these things that we have and all the information we have so that we can continue to live our lives and enjoy living in this wonderful state that we live in? So just most people are aware of this, but just to revisit this one more time to make sure we're all on the same page. COVID-19, so COVID-19 is the name of the disease itself. It stands for the COV is the shorthand that we use for coronaviruses. ID is infectious disease, and 19 is the year in which this was discovered. So the disease itself is COVID-19, which we're all familiar with. It is a virus. The virus name is actually SARS coronavirus number 2. And so sometimes you'll see SARS-CoV-2 used interchangeably with COVID-19. They're one and the same entity. There is a SARS-CoV number 1, which was another coronavirus that actually came on the scene back in 2002 and caused not a worldwide pandemic, but did cause an epidemic in China and did affect the city of Toronto disproportionately. So that's the original SARS virus. And SARS stands for severe acute respiratory syndrome. The current cause of COVID-19, SARS coronavirus 2, is very similar to number 1, which is why they were named that way. This was first identified back in December of 2019. It was originally traced to Wuhan, China. And at first it was felt like there was maybe some kind of ongoing outbreak related to a fish market. People were coming down with an undisclosed type of pneumonia that was causing severe respiratory syndrome. Obviously, everyone knows the rest of the story. Where it started in China, it quickly spread throughout Asia, into Europe, into the United States. There's likely an animal reservoir. There's certainly a lot of conspiracy theories that there was some lab in China in which this is where it originated from. Most of that has been debunked. The reservoirs, viral reservoirs from animals are actually incredibly common, and no conspiracy behind that. Also, something worth mentioning, coronaviruses are not new. Coronaviruses exist. There's lots of strains of coronaviruses, just like we do with flu, lots of strains of flu. Coronaviruses cause the common cold, so almost everyone on this presentation has probably experienced infection from a coronavirus. The difference, obviously, between the standard coronaviruses and COVID-19 is the degree of how sick people can get. However, there is a spectrum of disease, just like all things. So some individuals can have very mild symptoms, and some people can obviously develop severe symptoms and potentially die from it. So that's sort of the background of the virology. The transmission is something that's been obviously discussed ad nauseum. Certainly in the medical community, we think about this a lot because it sort of impacts how we think. Most respiratory viruses, including flu and the common cold, as well as COVID-19, are spread via what we call droplets. And the picture on the that you can see is sort of an illustration of that spittle that comes out when somebody coughs or sneezes. The range of these droplets, which often are large because of the saliva that they contain the virus, generally can't travel very far. So 3 to 6 feet is sort of the average what they think about, and that's where the 6 feet is considered contact. Obviously, these can land on surfaces, and so there is certainly the potential for you to be able to come into contact with these, even though somebody didn't directly cough on you or sneeze on you. These are what we call fomites, and so fomites are the infectious particles or droplets that land on surfaces that then you potentially touch unknowingly and then itch your eyes, touch your nose or mouth, and potentially introduce the virus into your system in that capacity. There is discussion about these, the airborne transmission and these aerosolizations, and so I'd like to make sure we understand the difference between a droplet and an airborne disease. So the droplet has that spittle. Airborne means that the virus stays suspended in the air and doesn't necessarily fall to the ground. COVID is not airborne. COVID-19 is droplet. A good example of an airborne disease could be measles. Measles, we've had measles outbreaks, and the reason it's so infectious is because it can literally linger in the air for a degree of time. And so if you're in the grocery store and you happen to be in line with me, you don't have vaccination to measles. I actually have active measles. When you go to the checkout stand after I coughed, you can then inhale it and then get sick. Tuberculosis is another common infection that's considered true airborne. Other things, so it's not truly an airborne disease. The distinction of the aerosolization are these small little droplets that maybe can linger when somebody coughs or sneezes and stay suspended in the air. And there's been a lot of discussion about this on what role this plays. Certainly they can be generated. Somebody that's singing really loudly, coughing really deeply, all of those can generate those aerosols. Certainly this happens with other respiratory diseases like flu. We know flu can actually do this as well. Whether or not this is a significant mode of transmission, we still do not know. There are certainly some studies that, again, usually in households or in very controlled settings in which there's not a lot of air movement and there's lots of people congested, where this may be a mode of transmission. And this is part of the sort of ongoing science that we're learning to understand and discover, but also contributes to some of the recommendations as to why we recommend masks or not wearing masks. And so I hope that's cleared that up a little bit more accurately. One of the things that we look at a lot, and certainly in my world, in the world of infectious diseases, is, well, how infectious is it? So if, and so there's a statistical method that we use, which is referred to as the R-naught. And the R-naught scale is basically a measure of infectivity. So there's some examples on this that give you sort of a picture of this. So H1N1 is an influenza or a flu virus. This caused a pandemic in 2009. And the R-naught was determined over time to be between 1.2 and 1.6. And so basically the concept is that if you have an infected person with this virus, how many people on average would get infected after coming into contact with you? So H1N1 is 1.2 to 1.6. The original SARS, coronavirus number 1, the original had an infection rate, an R-naught of 2 to 4. So on average, about 3 people would become infected after coming into contact with someone with this. You can see COVID-19 is somewhere between 2 and 2.5. Ebola, which was in the news a couple of years ago, 1.6 to 2. MERS, which most people probably aren't familiar with, is Middle Eastern Respiratory Syndrome, also a coronavirus, also causes severe infection, has an average infectivity rate between 2.5 to 7.2. However, that has been fairly self-limited. It's still more geographic in terms of exposure, and that's why you probably haven't heard about it. Its origin, it certainly couldn't affect camels and other animal hosts as well. So going back to COVID-19 specifically, the reason this R-naught is so important is because it tells you that if you have a group of people that are a population that have never been exposed to this, and in this case, we know most of the world had never been exposed to it, and you have an infectivity rate of over 2, that means that the likelihood of it spreading across cities and towns and across the world makes it much more likely. And so this is sort of the origins of how the pandemic started and why we're seeing the degree of infections that we're seeing. There is some other things I just want to mention up front before we get into the statistics about asymptomatic carriage and antibody testing. So there's 2 things. There's, again, a lot of stuff in the media about this, about people being asymptomatic and that they're contributing to spread, and this is why we're seeing so many surges in other parts of the country. So there is truly potentially an asymptomatic state, and that would mean that you are tested for whatever reason for COVID-19, and you test positive, but you have no symptoms. You have no symptoms of cough, no shortness of breath, no fever, runny nose, nausea, vomiting, loss of taste, loss of smell. You are completely fine, or you don't remember having any of these symptoms, which means you could have had actually a very mild case. We believe that asymptomatic carriage, you have very low copy numbers of virus, and you are unlikely to have a significant contribution to the infectiousness or infecting other people unless you have very close contact with those individuals. So within 6 feet, and maybe you share glasses or otherwise. Pre-symptomatic carriage is for those individuals that at the time they are tested do not have symptoms, but within 2 to 5 days of them testing positive, they do go on to develop all the symptoms associated with COVID-19 that I've already just mentioned: cough, fever, shortness of breath, fatigue, etc. We think the pre-symptomatic carriers, and this is not uncommon, so most people may not realize this, but when you get the flu, usually in the 48 hours prior to you getting sick, we can detect virus in your system, typically in the nose and in the mouth, a flu virus. And those numbers go up exponentially to the point where within 48 hours, when you finally have the fever, the chills, all this classic flu-like symptoms, the viral count in your secretions is actually extraordinarily high. And that seems to be the case with COVID as well, where people can, at that pre-symptomatic stage, have no symptoms, test positive, actually have a high viral load, but they're not feeling bad yet, and then they get sick. And we do believe that those individuals in that pre-symptomatic period are probably quite infectious, and because they're not feeling bad or they're only very mildly ill, may not realize that they're exposing significant number of people to potential infection. And again, this is in the setting of not following social distancing, masks, etc. The reality is at this point, we still don't know what is that critical threshold. How much virus in your system is enough to actually transmit, and then how long does it take in that time frame to transmit? We do know, and there's actually a paper that just got published in the Journal of American Medical Association in JAMA just yesterday, that actually does show that universal masking, good hand hygiene, and social distancing can impact this. And so even if you're fine and you're not feeling sick, and you don't realize you're sick, implementing these factors can have a significant impact on transmission. And so that is, at this moment, my plea or sort of scientific data that actually supports all these measures that have been going into place. Switching to antibody testing. So at the beginning of this, when antibody testing was out, the antibody tests were not very good. And so some people on this webinar may have actually been tested for COVID and may or may have not received a positive test. The tests now that are allowed by the FDA under emergency use authorization. So what that means is that it did not go through all the standard trials and things that we normally do. It's just they did enough tests to satisfy that, okay, this test looks probably good enough. The original tests that were initially authorized could cross-react with the coronavirus that we see all the time. And so we couldn't tell if it was the common cold virus you had or truly had COVID. We do not recommend this for diagnosis. You can still be shedding active virus and not have antibodies, so having a negative antibody test doesn't mean that you don't have COVID in the right setting. And certainly the other bigger question is, if you do test positive, what does that mean? In the setting of so antibodies are chemicals that your body produces after an infection goes into your system. There are different levels of these antibodies, and some of them are what we call neutralizing antibodies, which means they kill the virus or bacteria that was in your system. This is what we rely upon when you get vaccines for measles, mumps, rubella, or chickenpox, or other things. Usually with respiratory viruses, these are not long-standing. So there's some that potentially, sorry, my light just went out, there we go. There's some that are long-standing that you will have, like if you've ever had chickenpox, you have antibodies to chickenpox for life. Unless something catastrophic happens to your immune system. With cold viruses and flu, you may have some protection initially, but everybody knows you can get a cold again. Sometimes in a season, you may get 2 or 3 colds. Now, there could be different viruses, but it also is because the level of antibody that you have or the neutralizing antibody titers may not be long lasting. And certainly, again, there's data that's been coming out that shows that even if you were infected with COVID-19 and you knew you had it, you may not be okay for the fall. In the fall, you could get this again. And so there's a lot, the titers certainly drop precipitously, usually after about 2 to 3 months. They can sometimes not even be detected. And so I think that's important in terms of recognizing that even if you had COVID-19, you may still need to be careful in terms of making sure you're still following these same rules. I sort of joke, it's not the golden ticket. And so you aren't allowed to run free in the factory, even though you might want to. So who's at risk? Certainly there's different levels of potential risk for development of infection, and specifically for severe disease. And so obviously none of us like to be sick overall, but there's certainly groups of individuals that potentially are at a higher risk of actually ending up hospitalized or end up dying from this. And so what you see on this chart is looking at the rates of hospitalization per 100,000 and looking at the various changes based on your age. So if you're young and healthy, you generally, and I use the word young liberally here, you can see that the rates of hospitalization are much lower compared to when you start getting into the age over 65. When you get over the age, even if you look at 50, we start to see almost a doubling of the number of rates by this. And so certainly when you get over 85 and you start looking at the number of hospitalizations, it disproportionately affects those that are older and certainly more vulnerable. And I can tell you that even though I'm not going to show the mortality data over 65, mostly over 75 and beyond, is upwards of 80%. So if they end up in the hospital and they end up on a ventilator, it's almost guaranteed that they will die from this illness. So it is huge in terms of that impact on these populations. Others that have been shown now by looking at big population studies, since we now have a lot of good data on this, is that there are other cofactors that put you at a much higher risk for requiring hospitalization and probably ending up needing interventions, including ventilators. Individuals with chronic kidney disease, especially those on hemodialysis, chronic obstructive pulmonary disease, immunocompromised states, that could be transplant, that could be cancer, that could be HIV. There's sort of a broad spectrum of that. Obesity, so BMI greater than 30, has found to be an independent risk factor for development of severe illness. Cardiovascular conditions, congestive heart failure, coronary artery disease, cardiomyopathies, sickle cell disease, and type 2 diabetes mellitus. In most of the instances of type 2 diabetes, it's actually uncontrolled type 2 diabetes, so not just the diagnosis itself, but poor glucose control over time. Other studies have shown that these conditions could potentially put you at higher risk, but have not been shown to be statistically significant or statistically associated with severe illness. But certainly, again, all these are things that, if you think about, are potential conditions in which people are at higher risk of complications from flu. And so these are not a surprise in terms of being on the list, but may not have the same association with risk of hospitalization and potential mortality. I put this up because so first I want to sort of showcase the Johns Hopkins website. This, and the website address is at the bottom, or you can just Google Johns Hopkins COVID, and it is an amazing site. It has a lot of really great information, really great data. It is updated frequently and can give you kind of the lay of the land. And I remember seeing that, I took this snapshot back in February. We were only at 83,000 confirmed cases. This was worldwide, 2,800 deaths. And you can see that the majority of the cases at that point were concentrated in Asia and in Europe. And that was pretty much it. You can see you can count the number of dots in North America. And obviously we were counting those dots. We were watching that very closely. And I remember then Dr. Fauci put out the announcement. He said, if we don't pay attention, we could reach 100,000 cases in the United States. And I just kind of thought, well, maybe. Well, fast forward to as of today, we are at 13 million cases, almost 3.5 million in the United States. And you can see that Europe is still being plagued for this. Most of Asia is actually now dots that you can actually count. That does not in any way undermine the number of cases they've seen, but we have gone and far surpassed all of those. And as you know, we are nowhere near being able to contain this at this time. So the number of deaths continues to rise substantially. In the United States, we are seeing record number of cases every day and increasing number of deaths and hospitalizations. So I think the initial hope that with the change in weather patterns that perhaps we would see a slowdown, I think we were a little naive and maybe overly optimistic that this would be contained, and it certainly is not at this time. These are all, again, publicly available websites where you can look at this data. This is from the CDC. This is looking at the hotspots in the United States. The bright red is obviously where most of the cases of surge that we're seeing, New Mexico, California, Texas, Florida, places in the Northeast. In the United States so far, as you already saw in the Hopkins data, there's over 3.3 million cases. If you, about 1,000 cases per 100,000 people, because this is another way to look at it. Certainly, if you have more dense populations, you potentially would see more cases, and this sort of normalizes it and gives you a better sense of things. You can see here in Colorado, we are not the light yellow, which is the lowest number of cases. We're not bright red. But we're certainly surrounded by states that potentially have that potential and are certainly within driving distance. And so it certainly, this color can change pretty rapidly. One of the things I think that's been really interesting is really getting a better understanding of the data and the modeling. And this is where people from the School of Public Health have been amazing in terms of looking at a lot of these data and trying to help us predict when we would see surges and what we could see based on different measures. This is a study that actually, when the governor first put into effect the stay-at-home order, I actually sent as one of the experts on his, the governor's emerging epidemic expert, I can't remember all, it's called the GERC, but it's the response committee that's meant to be able to study, and it's a huge number of people, a lot of different experts, but they presented this data, and this was the data saying, okay, if you look at COVID and look at the number of cases and you implement social distancing, how would this change what we do? So this is the setting of the epidemic where you start to see cases rising and you do nothing. And you can see that the curve obviously just goes upward and would continue upward. If you institute social distancing, you could see and start that on day 20. So when it entered your city or your community and you started social distancing, you can see that you could reduce the number of cases from no social distancing by 40%. What's interesting is that if you wait one day later, sorry, the magnitude is even higher than that. The difference of 40% is one day later. So if you start on day 20 versus starting on day 21, you see a 40% reduction or difference in the number of cases you end up seeing. I think when all of us saw this data, I think we all thought, wow, okay, we knew it was a good idea, but statistically it really seems to make a difference. This is another way to look at this, and this was the Gates Foundation modeling for this. And so if you did not business as usual, you could have possibly 25,000 infections and 400 deaths in a community. If you reduce your social distance by 25%, you can see you decrease the number of deaths by more than half. You social distance by 50%, you go down to like just a quarter of those deaths, and you can continue to see the impact of that. Now that sounds great, right? So these are models. Do they actually pan out? This is the impact on Colorado. So this is sort of looking at two different things. So I'd like you to focus on the red line first. And so the red line is the number of positive cases in Colorado. The bars that you're seeing are the number of tests that were actually done. The green is that they were done in commercial labs or non-CDPHE labs, which is the state health department, and the brown is in the CDPHE. And so what you can see is that when it hit our state, and you can see that some of this is reflective of how much testing we were doing. The goal around here, around mid-March, is when the stay-at-home order went into effect. And the goal was to what we call flatten the curve. So rather than continue to see this going upwards, we wanted to sort of start to see it trend. We probably peaked right in mid-April, and you can see that it did exactly what it was supposed to do. It not only flattened the curve, but it started to decrease the number of cases. We obviously have had expansion in terms of what we can do, and the stay-at-home order has been expanded to safer at home. And unfortunately, you can start to see that we're starting to see a very slight uptrend. We are obviously desperately trying to make sure we don't end up back to where we were back in mid-March and early April, where we were over 10,000 cases that we're seeing. And the impact of this is that hospitals get overrun, communities get decimated because of the infections. And so I think that we are not done with this by far. We're hoping we don't surge to the same magnitude that we did before, but it is certainly a potential reality unless we are very careful and conscious of what we're doing and institute appropriate measures. Here's the cases in the United States in terms of the increases, and this is sort of, again, sort of a hot map, sort of similar to what I showed you before. And again, looking at the surges, and if you look at the color progression, we are currently in the teal, but we are not that far from moving to the dark blue, which is all those places that are having massive surges. Certainly, I think in the next week or two are critical in terms of looking at our numbers, probably consistent with people having traveled over the 4th of July weekend. And July 4th is a great time to be in Colorado. There has been variable compliance in terms of how well people social distance or wear their masks or face coverings. And certainly we have lots of visitors from other states that may or may not have realized that they were sick, that could have inadvertently spread it to other people. This is the 3-day average in Colorado. This is the number of cases reported. And again, if you start looking at these trend lines in the curves, you see we are starting to go back towards what we saw before. And so certainly we are keeping very close eyes on this. Again, this data is from both the CDC as well as from the Colorado Department of Public Health. All of these are public access. You can go in, you can look at the raw data. There's all sorts of really nice, great graphs. And again, you can put in Colorado State Health Department or CDC, and then you can find and put COVID with it in your search engine, and you can easily find these. The last thing I want to talk about in terms of COVID-19 and hospitalizations is just the impact it's had disproportionately on specific race and ethnic groups. And this is initially was seen and talked about in other states. And then when you started to see it in Colorado, when I started to see it, just when I was in the ICU, it really struck me that this is an interesting disease on many levels, but it's something that the medical underserved community is disproportionately being affected by this. And if you look at the rates of this is across the United States from March to June. If you look at the rates of who's being affected by this, it's again sort of one of these moments of pause, especially with all the things going on in the world. If you are a non-Hispanic, American Indian, or Alaskan Native, the rates per 100,000 is 221 compared to 50 if you are non-Hispanic, Asian, or Pacific Islander, or even less so if you're not in any specific ethnic group. This disease is disproportionately affecting individuals that live, that are non-Hispanic, Black, Hispanic, and Native Americans. Now, why is that? Some of it potentially has to do with population density, communities that they live in, less medical literacy potentially. The other thing that is not on this slide, but a lot of these individuals are disproportionately more likely to work in manufacturing or processing plants in which you're not allowed to social distance or cannot social distance consistently. And so I think that's something that I think as we're going through this whole pandemic, we all know that there are all sorts of issues in healthcare and certainly in disparities based on race and ethnicity. But I think this is just one more factor that we need to rethink in terms of how we outreach to communities and how we help communities be able to get through this, because they are being decimated at a different proportion than those that live in communities where there's more open space or their households only contain one family. So what about the future? I mean, it's hard because we're kind of in the future and yet we're not even 6 months into this whole disease process, which is remarkable. If you think about it, it hit Colorado end of February, early March. So we're only 4 months into this, even though it feels like we've been into this for years. And so I think trying to even think beyond 2020 is really challenging for me, much less 2 years in. This is from, this was published in the New York Times, and it's from the Center for Infectious Disease Research and Policy. And it sort of gives you these 3 different scenarios moving out over the next couple of years regarding what we can see. So the first model is peaks and valleys, kind of what we think of seeing with a new infection, which is common, where you can have up and down until we either have everybody that's either protected or we manage to somehow eradicate it. The second scenario is a very high fall peak. Certainly this is our nightmare scenario. We are terrified of what we're going to be dealing with COVID sort of lingering, and then flu coming into the season, and then potentially for other things. You know, we haven't seen big measles outbreaks in Colorado, which is good, although they've occurred in New York and California and other places. But the rates of vaccination in Colorado have always been a little bit on the lower end. And now if you look at the data coming out from CDC of just normal healthy people that we need to have herd immunity, children aren't getting vaccinated. Why? Because their doctor's offices were closed down. So all those normal well checkups that should have been happening, including immunizations, are now being delayed. There's probably some critical threshold at which we will see a decrease in normal, that we'll continue to see people falling behind on vaccinations, which makes us vulnerable, not only for flu, but for measles, mumps, and other things. I'm just putting it out there to add to that lovely imagery. And last but not least is this slow burn, where we never see another dramatic peak, but we continue to see this going on. Now, what if we had a vaccine? Would that change this? It would depend on how good the vaccine is, how long lasting it is, and whether the virus stays the same. Most respiratory viruses can mutate pretty rapidly and change. And so that's always even why we get a flu shot every year, because the flu virus is either a different strain or it's changed just enough to where the vaccine that we took last year may no longer be effective. I unfortunately have no idea what's going to happen, but we certainly, I can tell you from the medical community side, are planning for all of these scenarios because we just don't know. And the sad thing, I hate to say it, is that everybody sort of talks about, oh, well, it'd be great to go back to where it was before. We're not moving back. This is our new normal, and we have to sort of accept that some of the things that we used to be able to do without having to think about, we will have to think about for at least the near future until this either burns itself out, we all have been infected and are beyond that, or we have a vaccine or a treatment that allows it to sort of stop it in its tracks. Okay, so moving to other things. So these are the things, I was trying to think about questions that I get all the time in terms of like, what can I do? What can I not do? I want to enjoy my life to some degree. What do I need to think about? And a lot of this is really thinking through whether or not your sort of risk assessment. So if you're thinking about traveling, and summer is a great time to travel, and certainly we all want to take some level of vacation, things to consider. Is COVID-19 spreading where you are going? Is it spreading in your community? If you're going to be traveling, are you going to be within 6 feet of others during your trip or after your trip? Are you traveling with someone who's at high risk that could get really sick if they got exposed? Do you live with someone that you could, if you got exposed? So maybe you're like, I'm healthy, I'm going to go to Florida, I'm going to hang out on the beach, but I live with my 80-year-old grandmother. Is that really a good idea? Maybe, maybe not. Again, all of these are personal assessments that you have to make those decisions. And then obviously the bigger question, can you even go where you want to go? You're not allowed in Europe. I had a trip to Scotland that was supposed to happen last week. Obviously it didn't happen. I could have potentially gone to the UK, but I would have had to be quarantined for 14 days. And when you think about like, well, I just spent all this money to spend 14 days in a hotel room. Some people actually might like that, but it wasn't really on my agenda. So those are all things you need to consider. And really this is what we do in infection control, is a lot of risk assessment. So what are the risk benefits? What are the ways I can mitigate risk? So even if you're going to go to somewhere where there may be a high number of cases, what will you be doing? Will you be in an area where you are able to social distance, or you will be very good about having hand hygiene and masks available? And then obviously if you get sick and you have to miss school or work, how does that impact you as well? And how does that weigh in your mind? Again, CDC has a fabulous page specific on travel that can give you some more caveats, and actually even has a checklist of, if you're traveling, like these are the things you need to make sure you bring with you and sort of keep awareness in your mind. If you're traveling internationally and you come back, so let's say you do go to a country that you're allowed to enter, and now you come back into the United States, the current recommendation for most health departments is then you have to stay home for 14 days after your return and monitor for symptoms. And so certainly that is a big deal. A lot of people are teleworking, so that may not be an issue, but some people don't. So it's something, again, to know. Right now, there are no active cruises. So this blanket statement of being quarantined after cruises is not currently in effect. But when cruises do start to be able to be open, this may or may not still be a requirement. So again, it's important as you get closer to your vacation plans to see what the current regulations are and whether or not they will impact your decision on whether to still move forward with those vacation plans. Foreign nationals at this time that have been in certain countries are not being allowed back into the United States, with very few exceptions. So again, something to consider, especially if you have mixed groups of people that may be traveling. And then I put the CDC website here for the travel that I think, again, is really helpful. It has very good basic information, has nice checklists, and just can help you think this through. Because I think you still can go and travel in the US or even abroad safely, but you want to just be prepared in terms of what that means when you come back, and also what precautions you want to be able to take so that you can safely travel and not compromise your own health or compromise the health of others that you may live with or come into contact with on a regular basis. Another question that comes up a lot. At the beginning, there was a lot of question about animal spread and whether or not pets could be affected by COVID. And what if I got COVID and I have a pet, I have a cat, I have a dog? Do I need to send them away? What do I do with these things? Right now, we still don't know. We, again, pretty much believe that COVID did come from its origin from an animal reservoir, probably a bat, but we don't think that animals play a large role in spread. So even though it may have started in a bat, it jumped to humans, and now the spread is purely almost exclusively in humans. Certainly humans can give it to animals. There have been cats and dogs that have been tested positive for COVID, and they develop respiratory symptoms. Dogs and cats actually get flu, get pertussis, get other respiratory viral infections just like humans. The difference is that it's typically a strain unique to that particular animal. Many of you might have seen this in the news that lions and tigers at the New York Zoo tested positive, probably because their handlers were positive and exposed them. So it's certainly something that I think the veterinary community is very interested in and are certainly looking at. Again, the CDC has very nice information on pets and how to care for them if you're positive and what to do. I think there's probably less concern about you getting them infected. Certainly there's almost no evidence at this time that a dog or a cat will give it to you. But I think, again, just being conscious of space and conscious of interactions is still a very good idea. And being a dog owner, the value of having pets probably still outweighs the risk of potentially giving it to them or vice versa. COVID in schools. This is a great question that I think everybody across the nation is trying to grapple with. Do we let college students go back to school? If we let them go back to school, do we test them? If we test them, is that good enough? What about our younger children? Can they go back to school? Can they all go back to school at the same time? Probably not. Do we need to space them out? Do we need plexiglass? There are so many things. A lot of this really, I think, is unknown. I think some school districts have made decisions based on current data. Some are looking at models at what's projected. Some of them are trying to say, well, we'll plan for this, but we then maybe need to go to this. And I think it will so depend on how much is in the community, how well controlled is it, and then there's all these other factors, like how old is the child? Can they wear a mask? Can they socially distance? Can they do some of this outside? Can they not do it outside? I think there are so many moving parts to this that I think it is really, really tough. I do think that school can be potentially done in a controlled fashion. It probably will not be what we're used to by any means, unless there is almost no community spread of COVID. But I think there's a lot of unanswered questions. And I think there's still like high anxiety, because what if you do send your kid to school and then somebody gets sick? Kids generally have shown a lot lower rates of infection, but maybe then they get you sick, and then it sort of continues this cycle. And so, unfortunately, I don't have the answers to this. I think it will continue to be an evolving question. And I think, again, there's a lot of risk-benefit ratios. Certainly, a lot of pediatricians have come out and said, the benefits of having these children in school potentially outweighs the potentially low risk of them getting infected. Similar to what we don't take our kids out during flu season, but obviously this is a little different and has potential for a little different impact. And so I think there will be more to come, but I think there is probably no answer that's going to be acceptable to everybody. And there's still so many things that we need to work through. COVID in sports, same sort of thing. I think sports are great. Certainly being outside is great. I will say that there are different ways to play sports that are important and can have different levels of interaction. You can certainly shoot hoops with never coming in contact within 6 feet of people. So maybe that's, and you're outdoors, the air circulation is good. I also will tell you that casual contact in the outdoors, I'll talk about that in a second, is less likely or very unlikely to cause you to get infection. And that's very different than being cramped on a bus with everybody together, huddled together, going out to play a team sport. So again, risk mitigation can happen. It can be done in a safe capacity, but you also have to take into context of, well, who's in charge? How well are they actually enforcing these limits? Who are the children that are playing? What ages are they? Are they able to comply with these rules? And again, there's different sort of risk-benefit ratios. If your child's healthy, or maybe your child has asthma, these are things that you would put into consideration as well. And this sort of reiterates some of the things that I just sort of talked about. And these are conversations you would want to have with the staff and the coaches and with your kid. For some people, having them outdoors and playing is a great thing for them and is necessary for them. So it's something to sort of, again, think about and balance and not either overreact or underreact. COVID in summer camps. Again, CDC has a nice assessment tool on this. Again, there's different kinds of camps. There's day camps, there's camps that are purely outdoors, there's physical activity camps, and then there's overnight camps. And again, you want to ask those same questions. How are you going to enforce wearing masks or washing hands? How well are the areas being cleaned? How many people are going to be there? How many groups, and are they separated out? Do they do activities at different times? Again, these are great activities and definitely help, especially for children that have been at home all this time, and for the adults too. So I think it can be done safely, but again, you want to think through, and this is a nice video of like how to think about this. Certainly, if you're camping in the great outdoors and you're with your individual families, that's a great activity that is probably very safe, very easy to accomplish. And again, just being thoughtful about where you're doing it so that maybe you avoid some of the congestion. And certainly in Colorado, a lot of these things have been thought through in terms of they don't have every campsite filled. There is some allowance for distance to be, so that people can have that freedom to be outside and outdoors without necessarily getting affected or worrying that, oh my God, I'm too close to that tent next to me. Parks and recreations, there's lots of local and state regulations. They have limits on the number of people that are allowed to go. Again, I will emphasize outdoor activities. If you're running, hiking, biking, if you can maintain social distance, that's ideal. But if you have limited contact time, so if I'm running by you or I just happen to hike by you on a trail, the likelihood of me transmitting something, unless I directly cough on you, is highly unlikely. Again, having masks available certainly helps mitigate that risk. Swimming pools, COVID does not live in water, does not live in lake. So again, if you can keep distance between people that aren't normally in your immediate circle, the likelihood of you getting infected is incredibly low, and then allows you to still be outside and to enjoy that. Obviously, in spaces that have public restrooms and equipment, or you want to make sure that it's being sanitized appropriately. And I can tell you at a lot of trails that I've been to, there's little signs that say, you know, this bathroom was last cleaned at X time. And of course, having your own supplies, your own sanitizers and your own wipes, and again, masks are a good thing. So the question is about the death rate and the CDC epidemic level. And at some point, if there were 11 straight weeks of death declines, you think the CDC will declare the pandemic over? I think declaring a pandemic over is very challenging, especially with a disease like this, where there can be resurgence. And so sort of those models that I showed you initially, where we can get to where we see decreases in death and decreasing in number of cases, but then we see a huge resurgence. And so I think it's going to be a long time before anyone declares this pandemic over. And I think a lot of it will sort of play out in terms of immunity and whether or not we get enough herd immunity to mitigate that as well. Question about flu shots. I'm glad somebody asked that question. Yes, flu shot, I don't know that flu shot's going to protect you. Well, we know it probably won't protect you against COVID, but it'll protect you potentially against flu, which can combine with COVID. This is my other nightmare. You can get more than one respiratory infection at the same time. We don't know if one will sort of cancel the other out, but it kind of helps keep that out of the equation. And certainly from my very biased hospital perspective, the less number of patients we hospitalize with flu, sort of the less challenges we have in terms of trying to manage all our other patients. And so I am a big proponent of flu shots. I think it's a good idea. Probably getting it sooner than later. I usually sort of sit on the fence on this question, but as soon as it's available, I think it's a good idea. And it's just one less thing to have to worry about in the respiratory season. So I don't know that it'll impact what we see with COVID, but it certainly is a good measure in terms of getting you better. question about, since SARS had a similar R naught, what aspect of COVID-19 made it spread nationally and actually internationally compared to the original SARS? I think that is the million-dollar question. I find this incredibly interesting that when SARS, the original SARS in 2002 first manifested, we went all out in our preparations with the idea it would come to Colorado, it would come to the United States and spread dramatically. There's things that are different between 2002 and 2019-20. And I'd say one of the biggest difference was the amount of travel and the amount of international travel that occurs now. Back then, if you look at the rates of travel, it happened, but not to the degree that it does now. And so I think that was partially what happened. There were a lot of external controls that were put in early on that maybe potentially mitigated that as well. And there may be something unique about the virus. When you look at MERS, which has an R naught that's almost quadruple COVID-19, most of you may or may have never heard of it, and it still tends to be very geographically limited. So there's probably some other factor, whether it's vulnerability or exposure, or there are unknowns that I think that make this a really interesting question that I unfortunately just don't have an answer yet. All right, next question. Which individuals are potentially put at risk from wearing masks? Is data available on association of vaping? And is there evidence of mutation of the virus? So I'm going to go backwards in those questions that were asked. So evidence of mutation, we have not, there is actually some evidence that it's mutated. If there's some genetics analysis that's been ongoing, mainly in Asia. Whether those mutations are significant enough to make it a whole different virus, or if it's the same, but just maybe, you know, it's kind of like changing your hair color. It's still you, but it's maybe blonde versus brown. It still hasn't really changed significantly what you look like, versus completely changing me from a male to a female, which would obviously be very different. So I don't know that we know the significance of that. We should expect it because whenever these viruses copy themselves, inherently they make errors. It's just the magnitude of that error, whether it changes it enough to make you into a different person versus a subtle change is unknown. The potential association with vaping and serious infection, I have not actually seen any data. There certainly seems to be a higher risk, slightly higher risk or potential risk with smoking, which may associate it with vaping as well, but I've not actually seen any data related to that, so I can't answer. I'm not sure I completely understand the question of which individuals are put at risk from wearing masks. If you wear a mask, you certainly are altruistically, hopefully capturing anything that you might be brewing in the mask itself so you don't transmit that to someone else. Depending on the type of mask you have, there's different filtration levels of the mask that puts you potentially protection, so that if someone was coughing or sneezing in your proximity, the mask potentially would filter that and prevent it from going into your airways. And the last question I see is, for parents with young kids deciding on in-person school, what advice do you have on how to make that decision intentionally? I think obviously the health of your child is important, the age of your child and their ability to be able to sort of follow through with instructions. The classroom and what the contingencies have been made at the classroom. And I think those are questions you ask. How are you cleaning? How are you separating them? How are you going to stagger them? And then obviously your child. Some children absolutely benefit 100% from a structured environment in which with their other kids. Some kids do really fine on this virtual learning. And I think and maybe it's going to end up being kind of a combination of the two that ends up coming through. And I think obviously the option, because you may not have that option. It may be that the school district just says you're no longer able to do this. And that's kind of the way it's just going to work on whether or not you have that. And the last question, I will say the poll is back up, so please answer those questions for us if you would. Since coronavirus has been around for decades, were any vaccines developed for the old ones? The answer, unfortunately, is no. There are no coronavirus vaccines, and you know why? Because it caused the common cold, and so it's annoying. Most of us would probably prefer not to have the common cold, but from the economics of how expensive it is to develop a vaccine for the common cold, and because making vaccines once upon a time, even now, it can be really complicated. I think nobody wanted to invest in it. So I think it's a fabulous question. Unfortunately, it's never been done. And so I will also say that I don't think we anticipate having a vaccine till next fall, and that's very optimistic. That's if everything goes right. One last push on campus. We do have, our campus is a site for the vaccine trial. There will be stuff coming out about that. I think the trial opens in August, and so more to come on that. I think I got all the questions. At least I hope I did.
I think you did get most of them, and I'm just conscious of your time and everyone's time on this. Thank you so much for being here tonight. And if you have any more questions, I think you can just reach out directly to the alumni office and we can answer them as we have an opportunity to connect with Dr. Barron again. Thank you so much and enjoy the rest of your evening.